guess we can get started. Um, Good afternoon, everyone. Thank you for joining on a Saturday afternoon. Happy that you are here with us. My name is Zainab Jah, and we are going to be presenting on demystifying medication abortion for reproductive justice among Black and Latinx women. Briefly, we are going to go over the Gamma project that we are all a part of. We are going to show a medication abortion video, review some findings from our project, and then have a discussion about medication abortion. As mentioned before, my name is Zainab Jah, pronouns she, her, hers, and I am the research project consultant for Sister Love for this project.
Hi, I'm Tiffany Helstorks. My pronouns are she, her, and hers. I am one of the co-investigators on the project. I am an OBGYN at Emory University School of Medicine. I have subspecialty training in complex family planning, and I am an abortion provider.
Good afternoon, everyone. My name is Mariah Scales. My pronouns are she, her, hers, and I was one of the graduate research assistants for the Gamma Project, and currently I am a fellow through the Association of Schools and Programs in Public Health in the CDC.
Hi, everyone. My name is Bria Good. My pronouns are she, her, hers. And I worked as a graduate research assistant while on the project with Sister Love. And right now I work as a public health epidemiology assistant for the CDC.
Alrighty, so we're going to go into a brief overview of the Gamma project, and Gamma stands for Georgia Access to Medication Abortion. Pictured here is a flyer that we created at the very beginning of our project, right before we got like IRB approved, just to talk to the community about what the Gamma project was. We were very intentional about the ways in which we engaged in research with community. So we brought the research to them, let them know what we were going to be doing, just to at least get some initial feedback from community members. And briefly, our project is led by Sister Love. We are based in Atlanta, Georgia, specifically in the West End. We are an organization that works at the intersections of HIV and reproductive justice. We also have an office in South Africa as well. We have a health education prevention program in which we do free testing, counseling. We have support groups and a lot of community outreach events. We have a policy and advocacy program as well as a research program. So this project is what basically developed our research program. We were always engaged in research, but it definitely was the first one that we were really leading on. That was really big. This project is in collaboration and with support of Emory University's RISE, which is the Center of Reproductive Health Research in the Southeast, based at Rollins School of Public Health, and it is funded by the Society of Family Planning Research Fund. And the main aim of our project is to improve access to medication abortion for both Black and Latinx communities in Georgia. And pictured on the right are a few of the team members, including myself, Tiffany, and we have some of our CAB members and some graduate research assistants as well. So our project is community-led and is a qualitative methods design project as well. We have a community advisory board that we developed at the beginning of the study that is made of faith leaders, researchers, abortion providers, community-based organizers, and community members. We were very, very intentional about the folks that we wanted on the board, and we really wanted to have a lot of different perspectives to inform the research that we were doing. So our community advisory board has been phenomenal and really guiding our project. They have provided feedback on the interview guides we've developed, the ways in which that we recruit and engage in community. So they provided a whole lot of great insight as to how we can best do this project and be very community centered. There are two different phases of our project. Phase one being learning from key informants. So we interviewed 20 abortion providers, and this included clinic staff. So health educators, nurses, translators, et cetera, including physicians, and as well as community-based organizers and folks that serve Black and Latinx communities here in Atlanta. We use all of that information and we use that to inform the interview and focus groups guide that we have. We've done 28 interviews. We're still doing 2 more, as well as focus groups with Black and Latinx women in Atlanta. And the idea of all of these interviews is just to get an idea of barriers, facilitators that folks are experiencing when seeking medication abortion, along with their knowledge and perception of it. So in this project, we have been doing a whole lot of community-based dissemination. We were doing community events, but now that's going to shift into a more virtual space. We are constantly updating our website with information in regards to the project, and we have created a newsletter for each phase, and the second newsletter is coming out shortly, so be on the lookout for that. What we have planned is a psychoeducational video, and this session is kind of going to inform the psychoeducational video that we're going to create. We have a community advocacy training that we're going to create and clinical recommendations. So right now we're on phase 2 of the project, wrapping up with a lot of analysis. We have some preliminary findings that we'll show later. But what we really wanted to do is create a first draft video that really talks about what medication abortion is and really dive into the knowledge and perceptions findings that we've had. So what we're going to show you all is the video that we've drafted, very preliminary, and not quite psychoeducational, but really addressing knowledge and perceptions and some questions that come up a lot with medication abortion. And in order to do that, we are going to do a pre-test first for folks to take a pre-test before we take the quiz. So Mariah or Bria, if you could share the link in the chat box, that would be great. And we will give you all about 2-3 minutes to take the pretest. Mariah, if you could keep track of the findings, or actually I can do that. So I'll stop sharing for a minute. And give you all some time. We'll review some of the answers at 4 o'clock.
We have about 1.5 minutes left. I'm gonna share my screen so we can look at the answers that we have, and then we'll go into actually watching the video. So for question number 1, well, actually, I'll wait 1 more minute. I'm getting excited.
So for question number 1, medication abortion uses blank instead of surgery to end a pregnancy. It looks like we got all answers for medicine. Second question, the medicine used for medication abortions work blank % of the time up to 11 weeks of pregnancy. And it looks like we varied in 85, 90, and 98. Question 3, in the state of Georgia, law requires that a patient must wait at least blank hours between scheduling an appointment and having the abortion procedure. Looks like everyone said 24. Mifepristone and misoprostol are the 2 medicines that are taken for medication abortion. The procedure takes 5 to 24 hours to be completed. The first medicine that is taken at the clinic is mifepristone, which causes light bleeding or nothing at all. Next, misoprostol is taken at home and can be taken in the cheek only, either in the cheek or vaginally, or none of the above. So those are the answers we got. Medication abortion procedure can always cause 1 symptom. And everyone thought all of the above. Is medication abortion the same as Plan B? Everyone said no. And finally, does medication abortion impact one's ability to have children in the future? Everyone said no. Thank you all for completing that. And now we're gonna go into the video we've drafted. As mentioned before, it is a very early draft of it. We are looking to incorporate more people into the video just to make it more relatable, as well as being mindful about captioning, et cetera. So we haven't got to that yet, but we just wanted to capture some of the findings that we found and some information that folks wanted to know about medication abortion.
A medication, also known as the abortion pill, uses 2 medicines instead of surgery to end a pregnancy. The 2 medicines usually used in the procedure are mifepristone and misoprostol. They work 98% of the time if taken in the first 11 weeks of pregnancy. If you are more than 11 weeks pregnant, please talk with your doctor about in-clinic surgical abortion procedures. Laws about abortion are different based on the state you live in. According to Georgia state law, patients under the age of 18 need to tell a parent or guardian about the abortion procedure. You may call or visit an abortion clinic with trained health professionals who provide abortion care and schedule an appointment for the medication abortion procedure. Additionally, Georgia law requires that a patient must wait at least 24 hours between scheduling the appointment and having the abortion procedure. Some clinics offer that counseling over the phone. Once you've arrived at the appointment, you will discuss abortion options, review medical history, receive an ultrasound, get lab work, and if you choose a medication abortion and have finished the counseling 24 hours earlier, meet with the doctor to receive the medications for medical abortion. Be sure to notify your provider of any pre-existing health conditions and current medications you may be taking. To access a medication abortion, you would 1, realize you are pregnant, 2, find and call an abortion provider. Keep in mind, due to state restrictions in Georgia, not all gynecologists or family physicians are licensed abortion providers. 3, complete the required counseling. 4, go to abortion clinic for the medication abortion. 5, talk with the health educators. 6, get an ultrasound. 7, complete blood work. 8, meet with the doctor to get the first pill. 9, wait 24 to 48 hours. And 10, take the second set of pills at home or a location where you'll be comfortable and supported. To begin, the pills must be given to you by a physician, and it can take a while to receive the medication on the day of the appointment. Be prepared for an extended wait time. Mifepristone is the first medicine taken at the clinic and may be swallowed with a glass of water. Mifepristone stops the pregnancy from growing. Progesterone is the hormone that mifepristone blocks. This causes the lining of the uterus to break down. Some may experience either light bleeding or nothing at all. Next, you may take misoprostol at home or in a location most comfortable to you 24 to 48 hours later. Your nurse or doctor will provide you with written instructions and a number you may call with questions at any time of day, 24/7. You may take misoprostol by placing tablets in each cheek pouch for 30 minutes or inserting tablets into the vagina. If misoprostol is administered vaginally, it is recommended that you lie down for about 30 minutes. Misoprostol causes the cervix to open and the uterus to contract. Heavy bleeding and cramping are expected to start within 3 hours. The abortion pill process is very similar to an early miscarriage. The cramping and bleeding may last for a few hours and may include lemon-sized clots, so please be sure to plan ahead for the procedure so you are in a safe, private space. The process should be completed within 5 to 24 hours. You may experience nausea, diarrhea, dizziness, tiredness, or a mild fever. Seek urgent care if you are 1, soaking 2 maxi pads every hour for more than 2 hours, 2, experiencing clots larger than a lemon for more than 2 hours, 3, or experiencing fever, vomiting, diarrhea, and weakness for more than 24 hours. Be sure to have a follow-up with your nurse or doctor 1 to 2 weeks later to make sure that the process was complete and you are healthy. This follow-up can be done in the office or via telemedicine over the phone. Regarding accessibility during COVID-19, getting abortion care during the pandemic has been especially hard. Luckily, some clinics offer telemedicine for abortion. This means no touch, medication abortion delivery, and healthcare providers counseling via phone and video. Additionally, some providers have allowed for curbside care in which patients drive up, remain in their vehicles, and may receive abortion and contraceptive options, counseling, contraceptive injections, and even medication abortion. One common question is medication abortion plan B, emergency contraception, or the morning after pill? No, medication abortion is different. Medication abortion works to stop a pregnancy that has already started. Plan B, the morning after pill, and emergency contraception are all the same, and it works to prevent the pregnancy from happening in the first place. Medication abortion can be taken up to 11 weeks into the pregnancy, but Plan B has to be taken within the first 72 hours after sex to be the most effective. The average cost of a medication abortion is $300 to $800. The Hyde Amendment outlaws use of federal funding for abortion, so Medicaid cannot be used to pay for abortion in Georgia and many other states except for specific circumstances like rape or if the pregnant person's life is in danger. It is important to discuss the cost with the clinic or your doctor. Keep in mind that the price of abortions is dependent on the week of pregnancy and can change as time goes on. Many clinics do offer financial assistance and local abortion funds like Access Reproductive Care or ARC Southeast can provide money, arrange transportation, help with hotel stays, and even child care. ARC Southeast contact info, their phone number is 855-227-2475, or you can visit their website at arc-southeast.org. How safe is the process? Medication abortions are extremely common and safe. Serious complications are very rare. Will this cause side effects? No. The medication abortion will end a pregnancy, so cramping and bleeding is normal. But medication abortion will not cause long-term side effects. It is not linked to cancer, having trouble getting pregnant in the future, or poor mental health. How long into my pregnancy can I have a medication abortion? In Georgia, clinics offer medication abortion up to 11 weeks of pregnancy. That's 11 weeks since your last menstrual period. Will other people know if I had a medication abortion? If you take the second set of pills in a safe place, then no one will know you had a medication abortion. Clinics keep your records safe and confidential. For medication abortion, you do not need anyone to come to the clinic with you. What if there are protesters present? When arriving at your appointment, you may encounter protesters. Please remember that the decision to seek abortion care cannot and should not be swayed by anyone other than yourself. Where can I get a medication abortion? Here's a map and a list of the abortion clinics in the Metro Atlanta area that do medication abortions. If you are thinking about abortion, please talk with a healthcare provider as soon as possible so that you may be aware of all options available to you. In any case, rest assured that you have the final say in what is the best decision for you.
Alrighty. So we are going to move into the post-test, just the exact same test again. Mariah, if you could potentially share the link again, and I will just have this up. And we'll give you all about 3 minutes to complete the post-test. We'll give a couple more minutes and then we can share the responses. Stop sharing for a second while I pull up the responses. Alrighty. So for question 1, it looks like everyone answered medicine. Question 2, everyone answered 98%. Question 3, everyone answered 24 hours. Question 4, everyone answered either in the cheek or vaginally. Question 5, everyone answered all of the above. Question 6, everyone answered no. And question 7, everyone answered no. It's really great. I'm glad that this was able to work. Very preliminary, so we're happy that we were able to assist with that. So we will go into some findings, and then following this, we'll have a deeper discussion about reflections on the video, what we can incorporate moving forward, etc. But we wanted to share with you all some of the findings that we've had from the key informant interviews and community members that helped inform what we're going to be doing for dissemination. So as mentioned before, in phase 1, we conducted key informant interviews with folks that work in abortion clinics, as well as community-based organizers at Black and Latinx serving organizations. And some of the overarching themes that we saw come up, first was lack of awareness among clinical providers about Black and Latinx experiences and barriers to access. We had some providers express that they didn't realize that there would be a difference, or they could not name differences that Black and Latinx folks experience in regards to seeking medication, abortion, and accessing it. Additionally, when asked questions of how current policies impact access to medication abortion from Black and Latinx folks, folks also stated that they didn't realize there was a difference. Barriers to medication abortion are intersectional. So we saw folks that we interviewed in key informant interviews, of course, were speaking on what they perceived Black and Latinx folks were experiencing. However, immigration status came up, especially from folks in community-based organizations that work with a lot of folks in the community. So they recognize immigration status could impact folks' religions, impacted the ways in which folks thought about medication abortion. So there are different levels of things that impacted folks' knowledge about medication abortion and whether they're able to access it or not. Widespread mistrust of medication abortion due to mistrust in medicine and science. We had some community-based organizers that spoke on not trusting whether the medication abortion would work or not trusting whether it would impact their ability to have kids in the future, being skeptical about whether it would work more than surgical abortion. So that's something that came up quite a bit. Abortion restrictions that inequitably affect Black and Latinx access. So there were discussions about the 24-hour waiting period. There were discussions about the 6-week ban that was being written during the time that we started this project. So we were able to incorporate questions about that to see how that could impact folks' knowledge about medication abortion. And we did see that folks started to believe that abortion was already banned. So that in itself acts as a barrier to seeking medication abortion. Promising opportunities for medication abortion integration. So we were able to incorporate questions to see how folks felt medication abortion could be integrated into existing healthcare settings already. And we had a lot of great ideas that folks shared, including delivery of medication abortion, over-the-counter access, having the chance to get medication abortion in primary care settings. So just expanding the places and the different types of healthcare professionals that provide medication abortion. And last, one that definitely has pushed the psychoeducational video that we have is the lack of awareness and knowledge of medication abortion among communities. Across the community-based organizations that we interviewed, we found that a lot of them didn't know what medication abortion was and didn't know that it was an option for folks to have. And they spoke that they believed that the communities they serve also felt the same way. In regards to community member interviews and focus groups, as mentioned before, we interviewed folks in the community, and we also held focus groups to just get an idea of direct stories that folks had, or if they knew of other folks that had medication abortions, or even their knowledge and perception, attitudes, et cetera, towards medication abortion. I have 2 quotes here, both indicating a provider level impact on knowledge and perception or experience of medication clinic level. We had one participant state, I think that it should only be available at OBGYN, women's center or abortion center, areas that you can get proper medical education, and those are the safe places to go. So that's something that came up quite a bit of how folks felt comfortable about where they could seek medication abortion. This clinic level is something that came up quite a bit. We had this participant state, it was a very stressful process just to figure out how to even get an abortion if she needed, how to finance it without her having her parents' insurance cover it, if it was even covered. And also the experience was pretty traumatic. She bled for a couple of days, for a couple of weeks following. It was very painful. She wouldn't want to go through that again. So just capturing how the costs can impact it. And I don't know what the experience was, but something that did come up a lot is folks feeling like they didn't get enough information about how the process was going to go when they went home. So that's something that's really important too, just thinking about the information that's provided to patients, as well as long wait times came up a lot. So of course that contributes to folks having a negative experience and waiting a long time, and whether their information about when they're going to get the pills is communicated, et cetera. So that's something that came up. A few more includes religion, language barriers, and a lot of abortion stories, powerful abortion stories that we captured. In regards to religion, we had a participant state, growing up, it was just a sin to terminate a pregnancy, actually a pretty big view in my family. So we saw a lot how religion impacted folks' attitudes and knowledge about abortion and how they felt about it, and how it created a lot of silence within communities and within family members, and how if folks were seeking an abortion, they felt like they couldn't go to their family for help. Language barriers came up quite a bit as well. This participant started, I would feel more comfortable if there was someone speaking Spanish to me or was able to be there and also provide that support in Spanish if we needed. So that's something that came up as well, especially considering that the second pill is taken at home, and being able to have someone there that can accurately and relay the information to the patient and there not be a barrier there. And lastly, as I mentioned, abortion story came up quite a bit. This participant stated, I really didn't fully understand what was going on. I feel like things weren't really explained to me clearly. I was also rushed into then getting this birth control shot that I didn't fully consent to. I ended up bleeding for months nonstop. And that just shows the importance of making sure that folks are feeling like they're making the decision for themselves. Something that came up a lot was they felt like clinic staff were making the decision and pushing folks towards surgical or pushing them towards medication abortion, and how they didn't feel comfortable with that. So recognizing how those interactions are very, very important. As I mentioned before, we're a very preliminary stage of our findings, and we're excited to dive deeper into the analysis and the findings that we have to find more overarching themes that come up. From here, we're going to go into discussion of medication abortion. Mariah, if you could drop the link in the chat box. But the 3 things that we're going to cover is 1, reactions to the video. So we want you all to reflect on the video that was shown, your reactions, if you have any feedback. Following that, we're going to talk about how medication abortion is discussed in your community. So we want you all to reflect on how it's talked about, what people think or feel about it. And then we're going to talk about how you all think this information should be shared with those in your community. So really reflecting how folks are thinking about it, how they feel about it, and how they will really take this information. So I'm going to share this. So the link that Mariah just put in the chat box, it's a little fake breakout room, but just a way to get you all engaged in the work that we are doing. So first, Bree is going to go over this, and you all can edit this and you can drop your thoughts on these little sticky notes. But I'm over to Bree so she can lead this section about reactions and feedback.
Hi, everyone. Again, thank you so much for taking time out of your Saturday to be with us today. And as Dee said, we really just want to get your reactions and your initial thoughts to our video. We're very open to hearing your thoughts, your comments, your suggestions, because we really want to make this video as best as possible for the community that we're disseminating it to. And so feel free to enter your answers in the chat or raise your hand so we can unmute you so you can speak to us directly. We love discussion, so don't be afraid to talk to us. And our first question is really, what were your initial thoughts on the video? Was it appealing to you? Did you like it? What did you dislike? Okay, so we see that someone mentioned that the video is visually appealing and thought the info was easily digestible. That's great. Do we have any other thoughts about initial thoughts? Did you all see anything that was striking or really surprised you about the video? Because, we comparing the pre-test to the post-test, we saw that there was an array of answers to begin with, but once the video was played, you all had the same answer. So was there anything that really surprised you about medication abortion or challenged your current thoughts about it? If not, that's okay as well. We'd really love if you had any suggestions of what you'd like to change, if anything. If not, that's awesome as well. But please feel free to give your honest and open opinion. We won't be offended by it at all.
Yes, we want to hear all the feedback that we can be able to provide and incorporate within the video that we made.
Mhm.
And we appreciate the comment about it being easily digestible. We just want to also make sure that the language is understandable. I know that a lot of times when we come to conferences, we already have an understanding about medication abortion or an interest in it, but to the patient population that we're serving, is it is it readable at their level? Will they understand it? Were terms too confusing, too advanced, those types of things?
Mm. So we see the comment that says, I wish my provider had told me before a medication abortion that taking the misoprostol vaginally would prevent severe stomach cramping. Are you still typing? I also felt the amount of pain. Yes, let's make that smaller so we can read it completely. Okay,
Excellent point.
that is a
And as a provider, I appreciate you sharing this information. I think that one of the things that we need to do better at is setting expectations around what to expect once you get home. So yes, the vaginal route is also just as effective as what we call the buccal route or the medication between the cheek and the gum. And we actually can recommend this for patients that are already experiencing nausea and vomiting in pregnancy, or we let them know that if you're having some of those potential GI upset, that you can insert it vaginally to try to avoid that compared to taking it buccally. Another thing that I always like to do is talk about pain and pain management and pre-medicating before taking that medication, like taking the ibuprofen or other pain medications that we provide 30 to 60 minutes prior so that you have pain medication on board before the cramping starts, and then kind of setting the expectation around that. So I think that, like you said, a lot of our participants actually brought that up too, so that they're aware of what to expect. And that if they thought that pain would be a huge issue, then maybe the surgical route would have been more appropriate. So thank you for that comment.
Okay. I see the comment about, would you consider mentioning what to do if you are undocumented or different immigration status? I think that's a very important thing to include, especially since we are trying to reach Black and Latinx women. So we really appreciate that comment, and we'll definitely try to put that in there. Z or Tiffany, I don't know if you all have any information regarding that right now to share.
I know we are going to be very intentional about, we were intentional about the type of partners that we worked with from the beginning, and we have folks that work with folks of different immigration statuses. And so we definitely intend on working with them to have a more in-depth conversation about what we can do to assist. And Tiffany, I don't know if you have any experience with this as well that could help.
Yeah, so I think that patients are worried. And so I think that it sometimes can delay their care. Like they present later because they're so worried about their documentation status and whether or not that will limit their access to abortion. It should not. They can still access the care and we will still take care of them. And so just, I think getting that messaging out there from the different clinics that we're at to let people know that we do support them. I think the other biggest concern that's really tied in with that is being able to cover anything financially. And usually we're able to offer services to be able to cover for the medication abortion or the surgical option. So just being able to get that messaging out again so that patients are aware.
Thank you. There's a question. Was the info that it doesn't affect you in the future mentioned in the video? Yes, it was mentioned. I think that's a really important part to include because that's always has a lot of confusion around it. If there's a way we can make that clearer, we can definitely be open to suggestions for that as well. But it was included. And we're hoping that maybe we'll have time at the end to replay it. But we want to try to get through our other questions so that we can get your full reactions and feedback on it.
Yeah.
And
before we go on to the next one, so for the person that commented on that, it definitely was mentioned. It was towards the end of the video, but I wonder if we should elaborate a little bit more on some of those concerns about future fertility, as they did come up quite often. Other things that came up was safety of medication abortion, particularly among people that have certain comorbidities or other medical problems. So if I have diabetes, is it safe? If I have high blood pressure, is it safe? Will it impact my future fertility, was something that most patients asked. If I have a history of anemia, like there are very few contraindications to medication abortion. But I wonder if in the video it would be helpful to touch on it a little bit more. I think another big thing was mental illness, mental health, and how an abortion does not impact your mental health in the future, which we did specifically say in addition to fertility, but maybe spending a little bit more time on that to offer some clarity may be helpful. So thank you for that.
And I think we also, I think we're also going to be providing resources as well. We have to compile all of those together, but to really address like mental health, because I know folks stated in interviews that folks did experience anxiety, but not like long lasting mental health concerns. But we do still want to provide resources about that and like, you know, let folks know how they can handle that if that's something that is experienced.
I mean, it maybe even look like a frequently asked questions website or look that we can add to the video so that we can address all those types of questions, because it may be a lot to include it in the video, but it may be good to also have the resources, as you were saying, to add on to it. But in the respect of time, I'm going to go ahead and pass it on to Mariah so we can move on to our next set of questions.
And if you happen to remember what you thought was confusing, we can always come back to it.
Yes. You can still fill in all the sticky notes as you see fit if something comes up.
Do you mind going to the next slide? All right, so now we wanted to get you all's reflections on how you've encountered medication abortion being discussed. And so if you have had any instances where people were talking about it, if you've experienced it, or if you've heard second or third hand stories, what type of nonverbal language was used were discussing those stories? What type of facial language, body language? Even if you were, you know, thinking back to how you've talked about medication abortion in the past, do you think that you had any positive connotations, negative, any thoughts around how it's been discussed in your experience? We're super eager to hear that as well. And I'll just read the next few questions just to get all the juices flowing and give you all ample time to consider responses. So this was medically accurate language use, or was street language use, as my aunt used to call it. So, you know, vagina versus pussy or things of that nature. What type of medical language was used when discussing it? Was the process of how medication abortion discussed, or was it more so about the personal speaker's experience with medication abortion? And if you heard a personal experience with medication abortion, was it a firsthand recounting, or was it second, third, fourth? You know, I heard my cousin's sixth grade cousin had X, Y, and Z. So how far removed was the speaker from that individual experience of medication abortion? And then in what medium was medication abortion discussed? Was it verbal, social media, text, whispers, shouting, all those things concerning how abortion is discussed? We'd love to hear it. So same as last time, if you can think of anything, just drop it into the sticky notes, or you can raise your hand and we will unmute you and you can just chat and we can type it for you. And for the first question, this is any discussion of medication abortion? Yes, any discussion.
We would also like to hear if folks don't talk about medication abortion. I think that's also important to capture as well, or what you all feel like folks in your community would react to medication abortion or hearing about it. We're just trying to gain an idea of how we can best discuss it and what language we can use and what we can really address in the video that we're creating. And feel free to add in the speaker notes too. If you want to type a lot more, you're more than welcome to do that as well.
So the first comment, thanks. When we have talked about it at my organization, we wonder about the liability of abortion organizations getting involved, potentially expanding access to medication abortion. That's awesome. Or maybe it's awesome the way I'm reading it. For the person who wrote that, do you mind expanding upon what you mean by the liability of abortion organizations getting involved? The next comment, I heard it described as like a bad period, which was not my experience when I actually had one, was way worse. Yeah, I would agree that based on what we've heard from providers and individuals who've had one, it's not like a bad period. It's its own category of an experience. So I think it's definitely important if we are going to try to compare, the pain to something. It should be something that is, adequately describing what's happening or what's going to happen.
Yeah. So I think with that, which is often what we hear, I think that, and it's really hard when we are attempting to educate patients and our health educators are educating patients about what to anticipate with the experience, because pain is something that is so subjective, right? So a little bit of pain to me could be a lot of pain to Mariah, could be a medium amount of pain to Z. And for some women that already experience painful monthly periods, they tend to normalize that, right? Let's say you experience no pain during your monthly menses, and then to have this amount of pain just kind of takes you to like a 10, and you're like, oh my gosh, this is the worst thing ever. So yes, I think being able to explain it can sometimes be challenging. But we have to do a better job at that. And I think also explaining when it's appropriate to take the pain medication instead of taking it once you're already in pain and waiting for it to kind of kick in and to take into effect, compared to pre-medicating yourself to really help with that. But maybe there's a way. I know sometimes in research we use like a visual analog scale to show the amount of pain that people could experience, and then maybe just let them know that it can be variable along this scale, and that if it's something that seems really intense, that would be a reason to call us so that we can have like a more in-depth conversation about what's going on.
And Tiffany, I want to defer the first comment to you. So the first comment, I'll read it again. When we've talked about medication abortion at my organization, we wonder about the liability of abortion organizations getting involved, potentially expanding access to medication abortion. And in the chat, they expanded upon what they meant, meaning like if we wanted to provide a distribution but we aren't clinicians. We have heard of this happening, but are unsure if it's safe for clinicians to not be involved. I wanted to wield that question.
That's a good question. And so I think it depends on the state that you live in. There are certain states that mandate that the medication must be dispensed by a provider. And so, for instance, in Georgia, our state requires that. There are some states like California where a nurse practitioner or even a nurse midwife can provide the medication. But I think you kind of want to know the legalities of your state and who can do that. You also want to have certain things in place where if a patient has questions, medical questions about expectations or side effects, because I feel like sometimes a lot of things that patients may be concerned about could be a normal side effect to expect at that step of the process, but somebody that is clinical and is able to differentiate between something that is a normal side effect and something that would be more serious or concerning, in which they would want to either bring the patient back in the office for evaluation or have them be evaluated elsewhere by a provider to ensure that everything is being safely done, or that the pregnancy is passing appropriately. And so the biggest things are, if we're concerned about hemorrhage or excessive bleeding, if we're concerned about pain, or if we're concerned about the potential for infection. But you definitely want to check with your states, because you're right, that could be a potential liability. Although, we're thinking that we're allowing access and making this more available for patients, you definitely don't want to get your organization in trouble legally by providing something when it should have been given by, a physician or a mid-level provider. So you definitely want to check on that.
Thank you, Tiffany. So another comment that we've had is, I've heard about medication abortion as someone fixed their little problem, or it was something they did on their own, which usually didn't end well.
And maybe can you elaborate, do you mean like patients that are self-induced abortions? Like, are they getting misoprostol from the internet and then taking it themselves? Or do you mean like they're actually going to a provider, they're getting the FDA-approved regimen of mifepristone, misoprostol, and that's how they're kind of fixing the problem, so that we can better understand? We did in our interviews ask about, right, Z? We asked about how many people experienced self-induced abortions. I think that overall people are less inclined to tell us about that, but we didn't encounter many people saying that they've experienced it or knew someone that had.
I know there were discussions about how folks had heard that, like growing up, in which folks would self-manage abortion. But I remember there's one example of someone saying if you drink like a lot of orange juice. So it's a lot of like perceptions of like what folks could do to end their pregnancy on their own. But I don't think we had specific stories about self-managed abortion, but I do know in the key informant interviews, the community-based organizers definitely spoke on like terminology that was used to refer to
right.
And that was seeked outside of abortion clinic.
Right. So you brought up a really good point. So yes, getting misoprostol either over the counter, and it's good that you brought that up, and the fact that you grew up outside of the U.S. Mifepristone is not readily available in other parts of the world. It is actually very expensive. And so even for miscarriage management and abortion management in other parts of the world, misoprostol is the agent we use by itself. And so typically when it's used by itself, we actually have to give like a second dose at times, or multiple doses to completely expel the pregnancy. We're hoping now that there has been another like competitor company out there that's made mifepristone and it is now a generic, that it will be much cheaper and that patients will be able to use it in accordance to the FDA approved regimen. But yes, we have seen that people in other parts of the world and other countries do use misoprostol alone, and that you can either do it vaginally or do it buccally. And overall, it is, just as effective. I don't think it's 98%, but it still has a high efficacy at working. It just may take multiple doses of the medication. So I wonder if that's what you mean too, by the feminist groups kind of taught you how to administer it, what to do, and kind of what to anticipate with the potential side effects.
Thank you for that. And then our final comment Medication abortion is not something I've heard about from others' personal experience. However, I learned about it in school, but at this point, like 6 years out of public school, I only remember it as like some pills and it flushes you out. I also didn't know you take more than one pill. Uh-oh, let me get the rest.
And I think it's just in the office and outside.
Oh, okay, thank you.
I think.
Trying to make it a little bigger. Yep, you're right. I also didn't know you take more than one pill in the office and outside. So that's good to know that, this regimen does depend on location and it can be very situational, definitely considering day 2. And so I do think it's important, or the second phase of the regimen. And so I do think it's important that we highlight that it's not necessarily you just take some pills. It's more, thought that you have to put into making sure you have your support system around, making sure, you know what to expect and who to call if something, were to go awry. And so those minute details are super important just to paint a more clear picture on what someone can expect if they were to need this type of abortion service.
Yeah. And maybe too, like, so medication abortion has been around for a long time. It was actually first FDA approved in the early 2000s. So we're going on 20 years here. It got reapproved at this new regimen. I want to say maybe in like 2016, 2017, going up to 10 weeks and allowing for both buccal and the vaginal route. And so I wonder if to just maybe hearing about it, people just kind of missed the part about the in the office aspect of it. Because typically that first pill you take in the office, you really don't notice anything after taking it, right? Like you typically don't notice bleeding, you don't notice cramping, you may not notice this part that kind of flushes you out. And so maybe that's why you kind of only hear when people describe it more is about the second set of pills that really causes everything to like jumpstart and get going. And so maybe that's kind of why along the way you only heard about some aspect of it compared to the total 2-pill regimen.
That's also true. All right, and so, I have one final comment in the chat. Hi, that period comment was from me. I didn't need to read that. My experience was extremely painful, the worst pain I've ever experienced. And the best comparison I can think of it is the pain of having a copper IUD inserted.
Oh, first I thought you were going to say contractions. I've actually had some people compare it to childbirth.
Oh, wow.
I think it's hard to make that comparison if you've never had a child, but the people that have had children say when it really starts to hit, it almost feels like labor pain, which would be consistent because misoprostol is actually a medication that we give to induce labor if you go past your due date. But yes, I'm sorry that your copper IUD insertion was that tough. But yes, it can feel pretty intense. Most people will kind of describe it as this buildup of pain. It gets really intense at this moment, and then it starts to slowly subside. And when they look back and like retrospectively, they usually will say, oh, I think that maybe the pregnancy passed at that point because it was the most intense pain and maybe the heaviest bleeding, and then it slowly started to improve. And so again, pain varies. It's going to also vary on how far along you are when you had the abortion, because if you're 6 weeks, something that's 6 weeks that passes, it's going to be smaller than something that's 8 or 9 weeks that's passing. And so it's a lot of different factors that can go into it. I guess our question would be, what is a better way to kind of help people around the expectation for pain? And maybe that's something that, again, we can add to our video so that they can be aware of what they could potentially encounter. I always think it's better to have all the information and then be like, okay, well, at least I knew this was a possibility, than to go in thinking this won't ever happen and then it happens to you and you're like, oh my gosh, was that normal? So ways that we could kind of help prepare patients for that. We're open to any thoughts.
If you could put that in the chat or on a sticky note, that'd be great. And we're gonna switch over to Tiffany's part so we don't go over on time. But you still have access to sticky notes and chat in the meantime.
Okay, so my segment is really going to focus on how can we get all of this information to the community. So as researchers, we've done these studies, we're doing these things, we're looking at our data, and it's great for us to have and know and to share among our medical colleagues, our public health colleagues, but how can we really get this in the community to the people that it will have the greatest impact for? So what are your current thoughts and perceptions about medication abortion in your community? I know we kind of touched on that, whether or not we've heard it and what circumstances we've heard it. But how do we empower the community to increase knowledge and awareness around pregnancy options and medication abortion? What are some ways to disseminate medically accurate information about medication abortion so that everyone is kind of on the same page? Like, again, with the story that someone was able to share, how they heard, about it flushing them out, but they didn't know it was a 2-pill regimen. Like, what are ways that we can get medically accurate information out so that everyone knows what's going on and that they're fully aware about medication abortion? And then how do we best reach the most marginalized persons to ensure access to reproductive health services? And again, this is around abortion, but we can expand this to all reproductive health services because we want to be able to help those that are most in need. So definitely open to ways that we could disseminate this information. Any thoughts? Some of the things that kind of came up during our focus groups and interviews were access through like social media. Other people mentioned maybe having community engagement events. And so when we go out into communities and we talk about things like women's health or breast health awareness month and breast cancer awareness, or we talk about cervical cancer screening, or we talk about things like blood pressure, like preventive health things, also incorporating reproductive health, letting patients know that there are, or people know that there are options regarding pregnancy, let them know that there are options regarding contraception. So incorporating that aspect into engagement things within the community, whether it's a community health fair or something held at like your church, things like that. Other people talked about engagement through social media platforms, whether it's through Instagram or maybe through Twitter, being able to like offer just medically accurate information through these platforms so that patients could have a place, or people could have a place to go to look this information up if they had questions. Or even having an app, which I thought was a really great idea, to have an interface with somebody to be able to ask specific questions, maybe about what you're going through if you're specifically having a medication abortion, or if you have questions about wanting to terminate a pregnancy, being able to talk to somebody about the different options, what medication abortion is, the fact that it's a 2-pill regimen, what surgical abortion is, which option is going to be less painful, which option is going to have less bleeding, those types of things. And so those are some of the things that we've heard so far in our interviews.
And I see the about translation, and we will have the video in a different language as well. All of our documents that we have been creating have been in both English and Spanish, but we do recognize that there are folks that may speak French or Arabic and stuff. So I think that's something that we're definitely going to look into as well. And we have partnered with organizations that do serve like Spanish speaking communities. And so we have also talked about going to some of their events, having folks on our staff that are bilingual, being able to go speak to them directly as well. So that's something that we have been trying to be mindful of as well. So thank you for that comment.
Yeah. I also liked how you brought up for patients that don't have access to technology, because I too often bring that up, because not everyone has access to a smartphone. Not everyone has access to the internet or readily available access to the internet. So having some service to be able to allow those patients to also communicate with us. One of the things that we thought of is patients mentioned having a lot of support when they're in the clinic setting with us. So when you come into clinic and you're going through all of these stages of the process, you meet with our health educators, you meet with the provider, you meet with our nurse to go through your medical history. You feel really secure while you're in that environment, and then you leave and you're like, oh my goodness, who can I call? Who can I access after that? And we give information for our clinical nurse. And a lot of patients said, well, what if I don't necessarily think I'm concerned about the amount of bleeding, but I kind of just want to talk to somebody as I'm going through this process? And so we had thought of maybe even having like a support person or almost like an abortion doula, where it's like a number that you could call and you can ask someone any question about the process, even if it's not clinical, any concerns that you may have. I guess it would require, a phone, but it could even be a landline. It doesn't necessarily be a smartphone where you're calling us and you're able to ask us all these things. So we're trying to think of different things in case people don't have access to technology. One of the other things is having, pamphlets and brochures. I know at our clinic, we give a pamphlet out afterwards that goes through, and it has pictures. It goes through each step so that if you're a visual learner, you have pictures. If you like things in this bulleted format, you can also read it. We have some form of like the video that we go through with them as well. And so you have different ways to kind of access the information. I think Instagram and TikTok has been a great way to find digestible bites of info. Yeah, I definitely agree with that. The Insta page and generation have been, yes, really good at ways for me to get info. I think a lot of younger folks are disillusioned by the news and finding other ways to get. Yes, so you are very right. So we find that our younger folks definitely like those apps, Instagram, TikTok, and they're able to get information from that. And so that's one of the things that we're hoping to incorporate compared to news and like other resources that other generations may have used, just to get medically accurate information. I also like the idea of infographics and using that for people to understand. I actually didn't think of bathrooms, but that's a great idea.
It is a good idea. And
Yeah.
I'll discuss it in like 1 minute, but our next deeper dive into our dissemination plan outside of just the psychoeducational videos. So I'll let you finish up, Tiffany, and then I can give more information about that.
Yeah, these are great ideas. And I guess thinking of different venues that we could put this information at, because I feel like when we talked to patients, they told us that they identified places that they thought were safe spaces to get the abortion, right? Some people mentioned with your OBGYN, with your family practice provider, or with a provider that you built a rapport with. But I wonder if we can expand that when we're just giving information and knowledge about medication abortion, like you said, in stalls of maybe like, I don't know, the health department, right? Could be one place. Or I know I also work at Grady, which is our safety net hospital, and we have a teen clinic and we have a family planning clinic, and having them in those clinic spaces, but also having them in other places where you could just readily access the information. So just thinking outside of health spaces or clinic settings, that's a good idea. So thank you.
Tiffany, you have a comment in the chat.
Okay, let's see. Oh, okay.
From Louisa.
Okay.
And we'll probably, after this comment and this last sticky, we'll probably wrap up and then address any questions you all may have.
Wow, thank you. I really appreciate you for sharing this. And I'm so glad that you brought up the visual about the products of conception, because that is something that we've actually thought a lot more about now that we have extended to 10 weeks gestation. And the 10 weeks gestation is the FDA approved regimen at the gestational age limit, but we've done a lot of research around medication abortion, and our clinical practice is up to 11 weeks. And we know that what you see at 6 weeks and 11 weeks is very different. And our messaging around expectation about what you have the potential to see, we've definitely changed the language. So I really appreciate you being able to tell us that. And it's something that we're definitely working on so that people can have an understanding of that, and so that they won't be, thrown off guard when they do see certain things that look more than just like, a heavy menstrual period. So that's definitely something that we've been working on. When it comes to the emotional roller coaster of it all, I definitely think that certain places and programs do a better job at being able to prepare women for that. I know that at one of our clinics, we actually provide resources in advance just in case you experience, you know, everyone after an abortion in general is going to have a wave of emotions. People report feeling relieved, people report feeling sad, and it can last for days to weeks, sometimes months after. And so being able to provide resources and let patients know, please call us if you're experiencing this so that we can connect you with people to talk to, so that you don't feel isolated and alone. So yes, that's something that we strive to do. I know that some places do a better job at it than others. But yes, I appreciate that comment. So thank you. Thank you for sharing.
So you all have access to these slides. You can like use the link, or if you want to email one of us to get the link later. So you can keep adding on to this as you think of things. We would greatly appreciate it. And we're definitely going to incorporate it within our video that we'll do.
And I saw your last comment about the different places. Thank you. I'm going to write all those down. That's great.
So next steps going from here, psychoeducational video, we're going to be creating that. And you really using the input that you all have provided. So we're very, very, very much so appreciative of the information that you all provided for us. We're going to create educational materials. So definitely, you know, one-pagers on even our findings that we can disseminate to folks. We did create a one-pager to give to folks when we were interviewing, so they wouldn't walk away without information about medication abortion, but doing some more of that with different visuals, different brochures that we're able to provide to community-based organizations and just share in the public, as you mentioned. We're going to have community and clinical trainings around medication abortion as well. So our team will be working on developing that and creating policy briefs, because as you know, the impact of policy, that it impacts what folks think they have access to, even if they do have access to it and they think they don't. So just really working on like how policies can directly impact those who are most marginalized. So if you want to stay up to date with our project, we have our link here for Sister Love's website is www.sisterlove.org/research. We're going to be posting our psychoeducational videos there, our one-pagers of educational materials, as well as our newsletters, and opportunities for you all to assist us with dissemination and piloting things and getting compensated for it, etc. So please be on the lookout there. And just want to say a big thank you for spending your Saturday afternoon with us. We really hope that you enjoyed the presentation and got something out of it. This is our contact information here as well. And yeah, we'll take any questions quickly. I know it's a little over 5 o'clock, so we really appreciate you all. I'll leave this up for just a little bit. And thank you. Alrighty. Well, thank you everyone for joining us. And as I mentioned before, feel free to reach out to us if you have any questions or if you want to add on to the slide or get the presentation, anything like that.
Thanks, everyone.
Take care.
Thank you.